All right, so I kind of laughed when I got offered to talk about this because I feel like we're going back in time about 20 plus years when we were doing this fairly commonly, and then it kind of vanished for a bit, and then it's starting to make way again too now that we're all being asked to manage hypertension patients again. So no disclosures related to this topic specifically. Now, renal artery stenosis itself is actually pretty common. So we see it incidentally in 7% of patients over the age of 65, and it may be potentially a common etiology for secondary hypertension, but still representative of only about 0.5% or 5% of all the hypertensive patients. It's really common in patients with CAD, so if they have atherosclerosis, more common, you're going to see it on autopsy as well. It's also common in patients who have CKD as well too. They end up with cortical atrophy and whatnot too, so you'll see it up to a quarter of the patients. And many of these patients who end up with end-stage renal disease on dialysis will also have concomitant atherosclerotic disease. Certainly, it's a form of rejection. You see in transplant vasculopathy, and greater than 10% of these patients will go on to present to occlusion. So you can understand why there's a lot of interest in potentially, when you see these stenoses, you want to go ahead and stent it. So that's what happened years ago. Even when I was a fellow, we were doing a lot of routine unilateral and bilateral renal artery stenting because it seemed like a really good idea, but that really proved to have unclear benefits, and inconclusive results were kind of the norm. Drastic was a study that was just with PTA with really negative results. STAR, the endpoint was a 20% or greater decrease in the creatinine clearance, and this was reached in only a small percentage of patients who undergone stenting, and really no difference with the group that was medically treated. And they also had a lot of procedural complications. So they had 3 patients that died and 1 patient ended up on dialysis. So that's not really good when you're doing a trial. 2 big studies. I'm going to talk about Astral and Coral. So Astral was stent with medical therapy versus medical therapy alone. And these are the 2 big randomized trials that essentially kind of obfuscated the whole field. So the clinical syndrome was uncontrolled refractory hypertension, renal dysfunction, and also they had renal artery stenosis. The problem was they used all these different modalities to kind of define that. And then ultimately, the clinician was unsure if stenting or medical therapy is better. So you want to theoretically have a clinician equipoise there, whatever that means. But when you look at their demographics, they're pretty much the same across the board for all the usual risk factors. And also their lab values are also really not different at baseline as well. And if you look at the angiographic information as well too, really pretty well matched across the board with no real differences. So when we look at the safety endpoints, this was a big problem. So 24 patients experienced an immediate post-op complication. And you could say, well, I'm an interventionalist. I never have any complications when I do renal stenting. But in this trial, there was actually 7% of the patients ended up with a complication. And really only, if you look at the medical group, they had 1 patient out of 18 that had a complication. 88% of patients had something, which is a real big issue, some type of complication. So what about the outcomes? Well, there was no difference when it came to serum creatinine. The blood pressure was no different between either renal stenting or medical therapy. CV events, really no real difference there. And mortality, no benefit whatsoever. So what were the conclusions? There's no benefit of revascularization on renal function within these atherosclerotic patients in whom the patients, the clinicians were uncertain if they should revascularize or not. And there was really no differences in these outcome measures, and ultimately they said longer-term follow-up is necessary. But there were a lot of problems with this study, and this kind of has been the norm for a lot of the renal stenting trials. So this whole issue of uncertainty allowed for inclusion of patients who only had moderate renal artery stenosis. So, there was actually a fair number of patients, not quite half, but almost half of patients had like 50% lesions. And they also had patients that had minimal to no hypertension. So that's obviously not going to work. And mid-trial, the size was increased from 750 to 1,000 to accommodate for the crossover that was happening, and then was changed back to 700 patients again too. In the stenting arm, only 83% of the patients actually got a procedure, and only 79% were actually successful. So that's actually not good. And greater than 70% stenosis arm, they actually had patients with less severe stenosis. So the arm with the severe stenosis, they weren't severe. And assessment of the renal dysfunction, 35% had nearly normal renal function, and then a lot of these patients were lost to follow-up. So that's obviously going to dilute your outcome. Complication rates were really high. So 1 in 5 patients, 1/5 of the patients had complications in the procedure arm. And many of the sites were low enrollers. So they had fewer than 9 patients over 7 years. So this was a really slow enrolling trial. And there was also no prerequisite experience with the interventionist. So that means they had no way to ensure that, that these operators were actually good at what they were doing. And this is a problem that we've seen in some of the CLI trials as well. So what about CORAL? So CORAL was a study of a stent with medical therapy versus medical therapy alone. Again, the clinical syndrome here was hypertension greater than or equal to 2 antihypertensive medications, or they had renal dysfunction at stage 3 CKD or higher. And also they had evidence of atherosclerotic renal artery stenosis. So this could be angiographic, duplex, or core lab approved MRA or CTA. So again, lots of different modalities, not necessarily all equal in terms of defining who was actually found to have renal artery stenosis. No differences in the baseline demographics or angiographic characteristics. If we take a look at the intervention arm, stenosis was reduced to about 16%. And they typically use about 1 stent per vessel. Some folks ended up using embolic protection, which seems to be nice. But look at the angiographic complications. So there was a decent number of patients that ended up with dissections, branch vessel occlusions, distal embolization, perforations, vessel rupture, and pseudoaneurysms as well too. Fortunately, those last few were rare, but the others actually seemed to be unusually high. And then if we look at the event rates, really, you look at the event-free survival is no different between stent plus medical therapy versus medical therapy alone. And you go all the secondary endpoints, pretty much everything's the same. So again, really no difference between stenting versus medical therapy. And look at this, the line of unity kind of goes straight down the middle here. There's no difference when you look at these subgroups. So when we look at blood pressure is what we care about, again, no real difference with regards to initially, but later on, there was some suggestion that there was potentially a little bit of difference there within the stenting group at a later point. So they said there might be a late-term phenomenon that occurred there. So renal artery stenting did not confer a benefit in the prevention of clinical events when added to this comprehensive multifactorial medical therapy in patients with renal artery stenosis. But there is potential that maybe long-term there may be some improvements as well. But because of these 2 studies, it pretty much killed renal artery stenting for many years, and it became very unclear who should we be doing this in. Now, there are problems also with CORAL as well too. They excluded patients with FMD. Really can't put FMD in any of these studies. So I'm not sure it's a problem, but it's a feature of these types of studies. Really slow enrollment. Again, protocol change to allow patients that didn't have high blood pressure. If they didn't have high blood pressure, they had to have some degree of CKD. And again, unclear benefit. They also relaxed the translesional gradients as well too. So they allowed patients with lower gradients, and because they also allowed for all these different imaging modalities, many of these patients, they were diagnosed straight off of duplex. So they said, hey, they have severe renal artery stenosis, but when they went in to look at the angiograms, they didn't have significant disease. So almost half the patients had lesions that were less than 70% of severity. And because they under-enrolled overall, they really couldn't do adequate subgroup analysis. There was also no minimum drug requirements, apparently, when they actually went into the study, so that's not great. So these patients were not necessarily on multiple drug regimens. A lot of these patients had lower degrees of CKD, and there were also differential blood pressure cutoffs as well, too, which potentially added to a certain degree of bias. So these trials still haven't really answered the question regarding the ultimate benefit of renal revascularization in these different types of patient populations, because some subgroups may potentially better benefit from this therapy. And there's ultimately methodological issues with all these studies and also subsequent studies that have been done as well too. So when do you stent? Well, the best evidence still supports evidence for patients who have severe renal artery stenosis, over 80%, or they have a significant translesional gradient, and you can accomplish that with a high dose of dopamine to induce a gradient greater than 20 millimeters of mercury. And on top of that, there are multiple drugs with difficult to control blood pressure, so greater than 3 medications, or they have rapid deterioration of renal function, they have flash pulmonary edema or heart failure. Post-transplant vasculopathy is an obvious condition that you need to treat. FMD, treat this typically with cutting biliary angioplasty, not with stenting. And then patients who have sudden onset of renal failure but still have intact cortex. They don't have cortical atrophy. So these patients may potentially benefit. And ultimately, there's a question of operator experience. So do we need expert operators? Operators that know how to use no-touch techniques, potentially use embolic protection in the right patients, use imaging, and then also managing patients who have deterioration or complications. Like how do we take care of those types of things? Some of this will also potentially apply to the renal denervation world as more operators start doing it. Within that realm, thus far, it's been primarily expert operators, but when everyone starts doing it, we may start to see signals of harm in folks who start wiring vessels that they don't know how to wire into. So this is really important for us to understand as well. So in general, in summary, that's actually not my summary there, but in general, I think there's still a role for renal artery stenting, but ultimately, in the realm of renal denervation, it's going to be really hard for us to do another trial because the ship, as I think so-called, sailed. So I think it's going to be a long time before we can potentially do something of meaning. Thank you.